We now have Professor Coralie Graham doing the next presentation. She kindly gave us a presentation last year and she's doing a follow-up this year. She's an associate professor in the School of Nursing and Midwifery at the University of Southern Queensland. She's duly registered as a registered nurse and also as a psychologist, and has worked in a number of roles in both of these professional capacities. Coralie's research interests include equity, which is through the Ramsden cultural safety model, and treatments for chronic neuro-injury and stroke. Her presentation today is ensuring that all people in healthcare are treated individually and without bias defines cultural safety. In recognition of this, Australia's Health Practitioner Regulation Agency has mandated that all regulated health practitioners are required to complete cultural safety training. Recognising that people with a disability are people with the same individual needs as everyone, who need to be treated and are communicated with without bias. That's what cultural safety is all about. And I hand you over now to Coralie.
Thank you so much for that introduction. You can hear me okay?
We can. Thank you. Good to see you, Coralie.
Yes, you too. Thank you. And thank you very much, Dick, for your amazing presentation. Ironically, my own son had a brain injury about 2 weeks after Dick's injury. So, and that's created my passion for both of the research areas that I currently work in. And I'd been a registered nurse for a long time when my own son had his brain injury, which then I went and did a psychology degree trying to find answers for my son because I knew that they were not right. And so I'll share my presentation. But for me, this is not just professional, this is very personal. And really important that that we find solutions where we can. I'm going to talk really briefly about the stroke research. So my 2 research streams are about stroke, but neuro-injury more broadly, and also the cultural safety, and I'll talk more about that. So before I do go any further, I am Australian, and so I would like to begin today by acknowledging the traditional custodians of the land on which we meet today, and to pay my respect to their elders past and present, and extend that respect to any Aboriginal or Torres Strait Islander peoples here today. So the PSE research, so PSE stands for perispinal etanercept, which is a treatment that is being offered off-label in a single clinic in Florida in the US. So I personally became involved in this nearly exactly 10 years ago to the day that we took my son over to America for this treatment after doing a lot of research. He had been left with catastrophic disability as a result of his brain injury. And so I recognised that more research was needed. And so we set up a charity and funded the first clinical trial looking at post-stroke pain. I then stood down from the charity and went and worked with the research team on a phase 2 larger study. We saw amazing improvements in many people on that study. We haven't been able to publish that at this stage. More recently, only in the last few weeks, the PESTO was called the PESTO clinical trial from the Florey Institute in Melbourne, have published recognising that much more research is needed. So I'm currently seeking funding for a phase 3 study. So there's potential for this research for many areas of neuro-injury. So just really briefly about the neuro-injury, the way that it's understood to work is that post any kind of injury, it doesn't matter how the injury happens, there's an elevation in a protein that causes neurons in the area around the dead area to go to sleep. And basically the way that it is thought to work is that with the injection, that this dormant area is awakened. And we certainly saw on both the first and the second clinical trial, people have really quite amazing improvements, but we need more research. So just really, really briefly, it's an injection into the base of the neck above the spine, and followed by a head down tilt. You can see on the next slide, if my mouse will work, that there's a heavily vascular area here. There are no valves between here and here, and the treatment is injected into that area, and people are tilted head down on this bed for 5 minutes following that treatment. So that's the way that research works. I'm still involved in that research. I'm not going to give up after seeing the improvements that my own son had, and also many other people. My son wasn't on the clinical trial from his treatment in America. So the next thing, like I said, this is, it's not separate, even though it kind of sounds separate. But in order for people in healthcare, and this is my main teaching area as well as a research area, looking at keeping people, regardless of their of kind of who they are, what their makeup is, that people are people. And in healthcare, people need to be treated equitably. So the photo there is of Coralie Ramsden. She was a Maori nurse from New Zealand, and it's her model that is now mandated in nursing in Australia. So we were one of the first nursing programs to utilize to put the course together, and I've been teaching that for the last 3 years, and learned a lot about me, but learned and hopefully helped students to learn a lot about themselves, to make sure that they're providing unbiased care to everybody that they provide care to. So when she talks about cultural safety, most people hear the term culture and think of ethnicity, think of a culture different ethnically to mine. Certainly that's part of it, but culture is not just about ethnicity. So it may or may not involve kinship, but it is about all different types of cultures, and I'll talk more as we go through. But culture is very dynamic and mobile, and it changes according to time, and a whole range of other social, political areas. And I can see in Dick's presentation that music is and still is very much your culture. So that's definitely a culture. So many cultures that we are all part of numerous cultures as part of our day-to-day life, and that's important to us as who we are. If we're in care, in any kind of receiving any kind of care, whether we're hospitalized for a whole range of reasons, everybody needs to be treated in the way that they need to be treated, so that they are receiving person-centered care. Certainly we need all the biological stuff and making sure we get our medication and all that kind of stuff, but we need to be treated as ourselves, not just an object with a biomedical problem. For our students and ourselves, we need to ensure that healthcare workers understand their own cultures and understand that we can't just see somebody's culture by just looking at them, that we can't just make assumptions about who they are without asking them. And it's not an interrogation of, all of the details of their life, but certainly talking to people. It's all part of forming rapport, getting to know people, getting to know their interests, so that they can trust us with more private information as we go through. So we also need to understand that we all have conscious and unconscious biases. And so obviously the unconscious biases we don't know about. and they can very negatively impact on the care that we provide. And so we need to make sure that we are providing person-centred, culturally safe care. So as Shannon was saying at the start, it's now mandated for nurses in Australia, and certainly we're seeing many other healthcare professions making it mandatory as well in recognition. So our course is being used now. We have occupational therapists, physiotherapists, psychologists, speech pathologists, and so on, all doing in recognition of how important this is, all coming into our program to have the cultural safety, the Ramsden model cultural safety training. So we need to make sure that we, we're providing care regardless of gender, age, race, appearance, skin colour, sexual orientation, disability, religion, and all sorts of other subcultures within those. And certainly in this environment, certainly any kind of neurological injury, there would be a shared understanding that is definitely a culture. It's kind of like belonging to a club that you just really don't want to be part of, but there is a shared understanding. So Ramsden proposed a 3-step progression towards culturally safe care, starting with cultural awareness, cultural sensitivity, then reflecting on the impact of those things to create a culturally safe environment. And I'll just take you really briefly through each of those steps. So the first one, cultural awareness, is about developing an understanding that there's a difference between people and their lived experiences. So the way that we grew up, the political environment that we grew up in, our social environment. So what financial aspects we had, whether we had a whole lot of money or not much money, or, all of those things really have an impact on the way that we see the world. And so it's really the first step to understanding that there's differences and similarities between each of us, and they're not better or worse. There's no right or wrong. We're just all who we are as we grow and experience our world. So all of those things. Then in the second phase of the Ramsden model, looking at and we talk about legitimacy of difference. So this is where we teach our students about learning to reflect on their life, on their experiences, and to learn about others, to learn that it's okay that we're different to each other. It's not that anybody's better, not that anybody's worse, that we're all different to each other. We all have different needs, different ways of expressing ourselves, to be part of our world. So I'm just looking at my notes here to make sure I don't miss anything. So we must learn to self-reflect. So we must understand our own cultures and the biases. And these biases, like I said, the conscious biases, we might know that we're always suspicious of people with, who wear a purple jacket or whatever it is, whether it's about skin colour. We might be aware that we have a bias towards particular population groups. And obviously that's not safe in healthcare. But the most dangerous ones are unconscious bias. So where we have a bias maybe towards people with a disability that we don't even know that we have. And in healthcare, that is dangerous. I can remember years and years ago when my son with a disability, was admitted to hospital, and a nurse told me, that she would get back to my son, that she had some normal people that she needed to look after, and then she would come back to my son.
Oh.
And it was midnight, it was in the middle of the night, and he was so sick, and I just stood there. I couldn't even speak, and I was just like, and she clearly had no idea that that bias existed. So in the course that I teach, I love to write case studies that really challenge our students. My case studies generally have a disability, and there's often overlap as well, what we call intersectionality, where people have maybe belong to a couple of different cultural groups, like they might be dark skinned, or they might have a particular religion that maybe is a minority of the population. And so I expose students to those case studies so that they're exposed to those before, so that they can reflect on that and go, oh, wow, I had no idea that I thought negatively about people from particular population groups, so that they learn it before they go out into care, and then expose people to unconscious bias. So we need to learn about ourselves. So, like, say, for example, my cultures, probably, I hope some of you can understand me with my Australian accent. So, I mean, people look at people and just go, okay, I know who you are. You know, that you're white skinned, that you're a nurse, you're an educator. So I just put this together for myself, just to kind of show just how complex we are. I'm a lap swimmer, and so, you know, we have really quite a demented culture around, you know, a shared, I still find it odd, even though I do it every day, about water temperature. We great long discussions about that. My family here, we all have a shared understanding, particularly around my son here, who has a disability. I grew up on a farm, so definitely rural culture doesn't go away. Medical culture. So there's a whole range of different cultures, and all of us are like that. And our healthcare providers need to understand that they're not just, you can't see who you're providing care for without talking to people about learning who they are, so that, like, people like Dick, to make sure that music is part of his care. That's part of his life, part of who he is. So that he gets the care that he needs. So the part of the Ramsden model is looking at recognizing that we have a worldview, and so these are things that are taught to us. So as we grow up, we don't even know. Like, there were things definitely that I had as part of my worldview, that when I went to university, that when I met some of the people that I was kind of a bit cautious of, I had no idea why I was cautious of those people. But it really challenged my way of thinking, because I was like, they're me. And they are biases that we have been taught as part of our upbringing. And certainly we're seeing more of that now, because we don't just have our parents and our peers at school teaching us stuff, social media, TV, all of those kind of things that really strongly influence the way that we see the world. So what can we do about it, I guess? Like I said, in the classes certainly that we run, we look at all of these things, and get students to challenge the way that they see people who are from maybe a group that they don't understand. And so we need students to understand, and I'll use stroke and neuro-injury here as a culture, that there is a shared, immediate and unexpected life change. None of us right away and go, I think I'll have a brain injury. Like, it happens. And there's a shared understanding of that unexpected, confronting, life-changing experience that other people cannot know. And the shared disability and the impacts, the communication challenges, all of those things, and discrimination that should not exist. So that's really why cultural safety. And like I said, it's not just about neuro-injury. I've just used that as an example, but it could be about people's, you know, their skin color or their religion, or whether they're older people, all of those things. So it's now mandatory. So we need to make sure that everybody is being treated equally. We also talk about historical literacy, so getting students to understand how things that have happened historically. So in Australia, because of the way that our First Nations people were treated when the British arrived in Australia, and the colonisation of our country, that historical impact is still negatively impacting the health of our First Nations people up until still today. We have people who come into our care who are migrants, who are refugees, who have been through horrific things. We need to understand that historical impact on them so that we have some idea of making sure that we provide appropriate care and consider that in their training. So one of the other things that we talk about is just the language that we use around talking about people. So there's a term called othering, and we need to make sure that we don't other people and call them the disabled or the gays or the Muslims, and clump people together as a group, and which really suggests that all of the people who are in that group are all the same, and we're not. And so we need to make sure that the language that we use, if we're not going to talk about somebody who has a disability, we talk about them being a person with a disability rather than disabled person. Family members, we need to make sure that they're not all clumped together and called stakeholders, which is one of my least favourite terms in the entire world, because it creates a power differential where the people who aren't part of the group are you know, they're setting themselves up as higher in a more powerful position, and that creates unconscious bias. So we need to make sure that people are talked about as people, as their name, and so that removes that power differential. In our course, we also run bystander training, so that we skill our students up to and ourselves to be able to have some strategies using, whether we use a direct, an indirect, a distraction, or a protocol intervention, but we have some skills that we can use to protect people in our care. And it's been amazing. It's an amazing opportunity to have that training and have those skills, because typically in the non-medical world, people are often kind of, we don't know what to do, so we don't do anything, and we stand back. But we need to have some skills to be able to step in and help people. So yeah, developing the communication skills to advocate for others. So that's pretty much covers all of the cultural safety stuff in a very, very, very short period of time. It's obviously, we go much deeper than that in tutorials. We get into discussions with our students and get them to learn from each other. but I really enjoy teaching it because it really teaches us so much about ourselves, but also to make sure that everyone that we provide care for is treated in the way that they need to be treated. So that's everything that I had to say, but I'm really happy to answer some questions if anybody had any questions. Happy to answer any questions. Yes, Tina?
Just curious, as you're teaching these courses and your awareness is heightened, I'm just wondering personally, do you ever catch yourself in a phrase that you wish you hadn't said or that doesn't align with your true thinking and all of that sort of thing?
Yep, absolutely. And one of the things that I think we all need to learn to do is apologise. One of the pieces of assessment, the students had to write about a time where they were culturally inappropriate, that they did something that was culturally inappropriate according to the Ramsden model. And this student wrote to me and said that they'd never done anything culturally inappropriate. And I thought, well, they must be an angel because, like, I know we all have, and I certainly have. And a few days later, I caught myself, one of my son's support team is he's a beautiful man, fundamental Muslim in his life, and he and his wife have 5 children. Well, they had 4 children at that time, and she'd just fallen pregnant with the 5th one, and they were all under 6 years of age or something. And I said, we're going for a drive, and with Joel, my son, and he said, "Oh, she's pregnant again." And I said, "You really need to think about getting a better television." And as soon as I said it, I was like, "Oh," and I just said to him, "Look, I'm so sorry. I shouldn't have said that." So, and then I learned from that, and I learned that's maybe okay to say to other people, but not to him, even as something that was meant in good faith, but as a joke. So I think we just need to learn to apologise and learn from that experience and go, okay, don't do that again. Yeah. Does that answer your question? I think, like, none of us are perfect, but I think we need to learn to apologise as well. Yeah, thank you. Yes?
Do we have time for another small question? I would like to, first of all, it's a great presentation, and I completely agree with everything. I'm curious if you can maybe give some examples of biases that are specifically prevalent with locked-in syndrome. Like, for example, people thinking that people that have locked-in syndrome also have cognitive impairments and start talking louder to them, or things like this. Do you maybe have more of those examples of things we should be, aware about?
And certainly, I mean, even just people, I think people who are in a wheelchair generally, that often, and I've certainly seen it with my own son, and I've seen it in the community as well, where people will talk to me or talk to the family member rather than the person. And I just, certainly when it's me, I just go, I don't know, ask him. He's the one with the money. Like if we're at a shop, like, why don't you ask him? But, directing the question and just saying, look, I'm really not sure about that. What do you, and then turning to the person that's meant to be asked and asking them directly so that they can have an opportunity to answer. Yeah. I always use the example with my students. My son Joel, who has the brain injury, his behaviours are sometimes a bit strange, and but he's very, very smart, and people see the behaviours and they don't see the person, and they think he's really stupid. And I remember going one day to the shops, and there was 2 Chinese men in a tiny little shop, and they were doing a massage, $5 for 5 minutes. And so I thought, oh, okay, let's go and do that. He'd like that. So they didn't speak to him. I think they spoke to the support worker who was male. And so they're massaging Joel's shoulders. And one of them spoke to their colleague, their Chinese colleague, in Mandarin. And I could see Joel's head go up, and he speaks tiny bits of French and bits of Hindi and bits of Chinese, loves learning different languages. And they spoke to each other in Mandarin, and Joel's clearly gone, oh, they're Chinese. And he went, ni hao ma, like, hello, how are you? And they both just went, like, not only does he speak, but he speaks some Chinese. So I think really all we can do in that environment is direct the question and say, I don't know, let's just ask the person, even if they're, you know, not able to respond verbally immediately, and we need to say, well, you're just going to need to wait just for a moment while they answer you. Yeah.
Great, thanks.
That's great. Thank you very much, Coralie. Thank you for a really interesting presentation again. It was marvelous to hear. And it was very interesting to hear of the importance that we must each take personally to be aware of cultural safety and aware of being kind and thoughtful about others. But more important, how wonderful it is that at least Australia has now made it mandatory that all medical professionals have to learn all about every aspect of that and really rigorously incorporate it in their medical practice. It's so important. Thank you so much, Coralie. It was great to see you. It's evening time there for you, so you can head off to bed if you need to. It's all being recorded and you can watch it all later.
All right.
I'll speak
Thank you all
soon.
for your interest. Thank you.
Thank you, Coralie.